Okay, Prof, the floor is yours.
Good afternoon to all my colleagues. My name is Inaki Irastorza. I am a pediatric gastroenterologist working in Cruces University Hospital, and I am also a professor of pediatrics at the University of Basque Country in Spain. During this talk, I will try to talk about cow's milk allergy, the different kinds of adverse reactions to cow's milk, like the Ig-mediated allergy, non-Ig mediated allergy, lactose malabsorption, and other GI symptoms like reflux, the colicky baby, or constipation that might also be related to cow's milk intolerance, to cow's milk allergy, or to cow's milk adverse reactions. Over the last 70 years, we have seen a dramatic decrease in the prevalence of infectious diseases, together with about the same dramatic increase in the prevalence of immune diseases like type 1 diabetes, Crohn's disease, ulcerative colitis, asthma, or hypothyroidism. Among these immunologic-based diseases is asthma or allergy that has been increasing over the last 70 years, although seems to have arrived to a plateau over the last 10 years, which is not the case of food allergy that are still increasing. Allergies and hospital admissions due to food allergies. Around 50% of children, they will have during their infancy GI symptoms that have also been related to cow's milk allergy, like esophageal reflux, colics, constipation, failure to thrive, or chronic diarrhea. Approximately 1/3 of the children, the cause for this reflux, this colics, this constipation is cow's milk. It results that around 60% of infants, they will have their formula change because they have GI symptoms that their doctors, they think might be related to cow's milk. And 3% of these children will be admitted to hospital for investigations and for treatment. The European Union founded 15 years ago a research that took place in Africa, in the Americas, in Asia, and in Australia, in order to try to establish the real prevalence of cow's milk allergy. The result was that there were large geographical differences between the countries, from 10% in Northern European and North American countries, prevalence of cow's milk allergy, to less than 2.5% of cow's milk allergy in Eastern Asia. This could be due to racial and nutritional behavior differences, but also due to the accessibility to the healthcare system. The diagnosis of cow's milk allergy is based basically on symptoms and on the challenge given the cow's milk once there is a suspicion of cow's allergy to see if the patient develops again the same symptoms. There are other biologic tests that might help for the diagnosis, but that are not sufficient on their own to establish a diagnosis, like can be the specific IgE, the hydrogen breath test, or the intestinal biopsies, that they all may help to the diagnosis, but are not enough to establish a diagnosis. The diagnosis of cow's milk allergy is based on the improvement of symptoms of full exclusion diet, and it's important to be full exclusion diet. As I said before, a specific IgE might help for the diagnosis, but it's not sufficient. And it's also based on a positive challenge less than 2 to 4 weeks after the diagnosis has been established. Most guidelines, when it's arrived the time to do the challenge, establish that the challenge has to be done in hospital especially if more than 4 weeks have passed since the initial diagnosis was done and since the patient has been on a cow's milk-free diet. Only in some specific diseases like eosinophilic esophagitis or chronic enteropathy or chronic food protein-induced enteropathy, only in those cases the challenge can be done outside the hospital because of the risk of severe reaction in case the challenge was done outside the hospital, especially if more than 4 weeks have passed after the introduction of the exclusion diet. For the treatment of cow's milk allergy, the treatment is the full exclusion diet of cow's milk allergy, and it's necessary to give a milk substitute in order to provide to the child all necessary nutrients, especially calcium, for example, to the child. So there are several options. There is the soy formula, the extensive hydrolyzed cow's milk protein formula, elemental formula composed by amino acids, the partially hydrolyzed rice formula, and also the other animals or other mammals' milk. Soy formula has the advantage of being cheap, but has the disadvantage of its content of phytoestrogens and phytates that might be related to endocrinological problems and problems with absorption on divalent cations like magnesium of calcium. According to most guidelines, soya milk or soya formula cannot be given to infants below the age of 6 months, except the only exception is galactosemia. And the other disadvantage is that 10 to 40% of children, of infants allergic to cow's milk will also be allergic to soya formula, especially in the case of non-IgE mediated allergy. The gold standard of treatment or substitutes, according to most guidelines for cow's milk allergy, is the extensively hydrolyzed formula. Despite being the standard, 77% of children allergic to cow's milk will also be allergic to cow's milk extensively hydrolyzed formula. The other problem it has is that the taste is not very good. It doesn't represent a huge problem with the infant is 1, 2, 3, or 4 months old, but it's a real problem if the child has been breastfed until the age of 8 or 10 months, when he will probably refuse to drink, to eat hydrolyzed formula, extensively hydrolyzed formula, because of its bad taste. There is in its favor a cultural component that is for the last 100 or 120 years, the substitutes to mom's milk in Europe and in Northern America has been cow's milk. So in general, the population accepts very well highly hydrolyzed formula coming from cow's milk protein, and this is in its favor. Elemental formula that is composed by individual or isolated amino acid. It's effective in patients with both IgE mediated and non-IgE mediated allergy. The disadvantage it has, it's very expensive. Hydrolyzed formula, at least in Europe, the price is double of common formula, and elemental formula is around 3 to 4 times more expensive than the normal formula sold for infants. And the other disadvantage it has is that the taste is also very, very bad. Is as bad or worse than the taste of extensively hydrolyzed formula. We also have another option. This option has existed for the last 10 years or so. That is the partially hydrolyzed rice formula. It is effective for both IG-mediated and non-IG-mediated cow's milk allergy. It has a much better price than extensively highly hydrolyzed formula and elemental formula, and it also has a better taste than extensively hydrolyzed formula and elemental formula. The disadvantage it has is that in most European and American countries, it has against its favor that there's a cultural component that we have for the last 120 years, 100 years, 80 years, 70 years, we have not been used to use any formula that does not come from cow's milk. So there is a cultural prejudice against using rice protein as the base of a formula. We will talk about it later. So why not to try a rice formula? Basically, as I have just said, because of cultural prejudice, and there are also safety issues that I will try to prove that in fact, they don't exist. There is no risk for the use of partially hydrolyzed rice formula. I will go first for the cultural prejudice. So basically, infant formula was developed in Western Europe and in America over than 100 years ago at the beginning of the 20th century. And the mammal we had in Europe and in Northern America was the cow, and children who could not be breastfed were fed with cow's milk. So obviously, when the first industries started to develop a formula for infants, they used what it was used in the streets, what it was used in their countries, what was cow's milk. That was the most common mammal in our culture. If the first industries and the first researches about infant formulas had been developed in Scotland, instead of using cow's milk, they would have used sheep milk. And if the first researches about infant formula had been developed in Arabic countries, they wouldn't have used cow's milk, but camel milk. There is a couple of very interesting publications about which milk of which animals could be used in the event of a cow's milk allergy. And it's called the kosher epitope that basically says that animals, the cross reactions between cow's milk and sheep or goat milk is very, very high. So if a child is allergic to cow's milk, has more than 90 or 95% chances of being allergic also to sheep and to goat milk, but has less than 20% of chances to being allergic to camel milk, to donkey milk, to horse milk, or to pork milk, which is about the same as the chances a child allergic to cow's milk to be allergic to soya formula. So it could be a good option. Obviously, the first challenge should be done in hospital just to make sure the child is in this 70 to 20% of chances he would have to be allergic also to these animals. It could be an option in some sociologic circumstances to use camel milk, other animals milk like horse milk, or donkey milk, or camel milk in children allergic to cow's milk when the parents cannot afford hydrolyzed formula sold in pharmacies. So if we look at the map, of the world map of lactose malabsorption, we can see that basically non-Caucasian populations have lactose malabsorption. If we look at the consumption of cow's milk, we see that it follows about the same pattern as lactose malabsorption. Cow's milk is basically consumed in Caucasian countries, in Europe, in North America, and in Australia, whilst patients with important population of non-Caucasian origin, they tend to consume much less amounts of cow's milk per year. And this map is about the same as the map of rice consumption. In countries where cow's milk is consumed in huge quantities, the rice consumption is much lower. In countries where cow's milk is consumed in little quantities, in small quantities, rice consumption is consumed in high quantities, as you can see here in Eastern Asia, which is the case of in Indonesia. So basically, adults eat rice where they don't drink milk. So it's obvious that there is a cultural prejudice against using rice and as a substitute for milk for nutritional, tradition and cultural behaviors. But let's go for the safety issues. There are issues about the protein's quality. There are issues about growth, weight, bone mineral density, fractures, etc. There are issues about the effectiveness of rice partially hydrolyzed formula for cow's milk allergy. And there are also issues about toxicity due to heavy metals, especially arsenic, the content of arsenic in rice in the world. Let's go for the first one, the quality of proteins coming from rice. In cultures where rice is the basis of their diet, like can be the case of Eastern Asia, but also the case of southern Spain, there is a habitude of consuming cereals together with legumes. So putting legumes together with cereals results in high quality proteins because legumes lack of methionine as cereals lack of lysine. When they are put together, there is no absence or no lack of any of these amino acids. So when analyzing the amino acids of formulas made of partially hydrolyzed rice, we can see that the content of lysine and tryptophan is the same or even higher than it is in formulas that come from cow's milk protein. So there is no issue about the quality of proteins. The amino acid compound of this formula is adequate for the children and it results in high quality proteins. Well, what about growth? What about bone mineral density? What about these kind of issues? Is partially hydrolyzed rice protein formula good for growing, good for putting weight, good for the bone, for mineralization, etc. So there have been published several papers already that prove that rice-based formulas are absolutely adequate for the growth from the point of view of weight, of height, as you can see here in this paper published by French researchers, or in this paper also published by French researchers. So they have proved that infants that have been given partially hydrolyzed rice protein-based formula, they grow, they put weight, the BMI is exactly the same as in children who are fed with extensively hydrolyzed formula or with normal formula. So what about the effectiveness against cow's milk allergy? Is partially hydrolyzed rice formula effective in patients with cow's milk allergy? So basically the answer is yes. Many papers have been published already proving than less than 5%, the same as with extensively hydrolyzed cow's milk protein formula. Less than 5% of patients who are fed with partially hydrolyzed rice protein formula, they develop adverse events when they are given this formula. So it's a safe formula. From a different point of view is that acquisition of tolerance is not just feeding the patient and the patient not having allergic troubles, but also when is this child going to develop tolerance to cow's milk. So in this study published 11 years ago, you can see that patients who were fed with extensively hydrolyzed formula have the same speed of acquisition of tolerance to partially hydrolyzed rice protein formula, exactly the same. So there are no differences from the point of view of tolerance in allergy, and there are no difference from the point of view of acquisition of tolerance in these infants. This paper was published last year by a French researchers group. Apart from reviewing the data nowadays available about growth in these children, they also looked at the prevalence of fractures and the data available up to date in bone mineral density, and they saw that children who were fed with partially hydrolyzed rice protein formula, apart from having the same growth, BMI, acquisition of tolerance, they didn't have more fractures than children who were fed with infant formula or with extensively hydrolyzed infant formula. And in the few papers that have been published about bone mineral density, there were no differences between these children and children who were fed with normal formula or with extensively hydrolyzed formula. So we can say from this point of view that partially hydrolyzed rice protein formulas are safe from all those points of view. So what about the arsenic content? What about the heavy metals content of rice? So we have maps of the arsenic content of the grounds and of the waters in different areas of the world. And we also have more specific maps of, this is a map of Spain, of which areas have the higher content of arsenic in their ground and in their waters. So basically, is in order to produce this partially hydrolyzed rice protein formula is basically as easy as using rice coming from areas with a low content of arsenic that are well known. Just in case, a research was done by the Queen's Elizabeth Queen's University in Belfast that was published 3 years ago, and they found that the levels in hydrolyzed rice formula are well within the safe range as stipulated by the European Food Agency and the World Health Organization. So basically, up to date, the rice, partially hydrolyzed rice formula are safe from this point of view. There is no concern about its content on arsenic. So basically, as an abstract of my talk, we can say that there is obviously a cultural component against using partially hydrolyzed rice formula, basically because for the last 100 years, the origin of special formulas for infants has always been based on cow's milk, but it's just a cultural component. There are no scientific basis behind it. And from the safety issues we commented at the beginning of the talk, we can say that the protein content is good. There are no doubts that it doesn't has insufficient amounts of tryptophan or lysine, so the quality of the proteins is quite high quality. There are no issues about growth. There are no issues about fractures. There are no issues about bone mineral density. There are no issues neither about allergenicity. Is partially rice hydrolyzed formulas has about the same safety pattern as extensively hydrolyzed cow's milk protein formulas. And from the toxicity point of view, we've seen that it has been looked at it, and the content of arsenic in these race-based formulas is well below the maximum amount permitted by the regulatory agencies in the world, in Europe, and in the Americas. So why to use partially hydrolyzed rice formula? An obvious reason would be that there is a lack of lactose. In countries with a high percentage of population with lactose intolerance, is a much better option than using cow's milk-based formulas. It has a low osmolarity, which is an advantage compared to amino acid formulas and extensively hydrolyzed formulas that have a much higher osmolarity than partially hydrolyzed formula, and is effective against patients with cow's milk related enteropathy or food protein induced enteropathy. Is a good option for patients with acute gastroenteritis, and it's also a very good option for patients or in countries with a very high racial lactase deficiency. Apart from this, partially hydrolyzed rice formula is enriched with symbiotics with fructooligosaccharides, which are long-chain oligosaccharides, and probiotic named Bifidobacterium infantis MI1 that has proved that it improves tolerance to cow's milk, that it reduces wheezing episodes during the first year of life, and it also reduces the incidence of acute gastroenteritis, especially those gastroenteritis, those diarrheas related to viral infections. There have been many publications regarding to FOS, to FOS, to fructooligosaccharides, and to the use of Bifidobacterium for reduction of allergic episodes of upper and lower respiratory tract infections, and so on. There is huge literature about it. And finally, there is also another point that I would like to express is that the taste. When we come to infants who are 1 or 2 months of age, they will probably be able to swallow, to eat almost any milk or any formula, amino acid basic formula, extensively hydrolyzed formula, partially cow's milk hydrolyzed formula. But the problem arrives when a child has been breastfed until the age of 8 or 9 months, and suddenly the mom decides to change to cow's milk, and the child develops allergy. In that cases, the child will probably reject the extensively hydrolyzed formula, or the amino acid formula, because of its bad taste. And although partially rice hydrolyzed formula, they don't taste as good as mom's milk or cow's milk, they taste much better the amino acid formulas and extensively hydrolyzed formula. So it's a very, very good option, and I would say it's probably the first options for infants from the age of 7, 8, or 9 months, when they need to be put on a cow's milk exclusion diet, because almost sure they will reject the extensively hydrolyzed formula, and they might spend days and days eating other foods instead of drinking extensively hydrolyzed formula because they really dislike it. Because the taste of partially hydrolyzed formula is much better. I think it's a very, very good option in this period of time of life between the age of 8, 9, 10 months to try a partially hydrolyzed formula because I think it will be much better tolerated from a taste point of view than other special formulas, extensively hydrolyzed or amino acid formulas. And also why to use partially hydrolyzed formula? Basically because the last guidelines of most scientific societies were published over 10 years ago. So 10 years ago, partially hydrolyzed rice protein formula it didn't exist, or even if it existed, it was very, very little developed in the markets, and so they didn't take it into account when they prepared their guidelines. But nowadays, most or all scientific societies, they accept partially hydrolyzed rice formula as an appropriate option for children with cow's milk allergy. The French Society, the European Society for Pediatric Gastroenterology, Hepatology and Nutrition, the World Allergy Organization, and many other societies. Thank you very much for your attention. And if you have any question, I will be happy to answer to it.